It's always good to be here at the IAOMT. Phil and I look forward to this because it's such a good group to come to, because everybody's always friendly, and so we usually have a good time here and try to give you all something worthwhile to look at that we've discovered over the many courses of many years doing ozone therapy. And so we wanted to talk today about some new things that we learned, and if we get, there we go. The American College, I've got to read this disclaimer. I do not have any financial interest of a product in my talk or with any companies offering grant monies for this continuing dental and medical education program. The financial interest I have is in thoroughbred racehorses, but that's a negative, not a positive. So, as my wife can tell you and everybody else. Now, what do you have those horses for? Well, that's fun. But anyway, Phil and I went to Capital University of Integrative Medicine, and at the time we were there, we were introduced to ozone therapy. And when we were introduced to ozone therapy, it was kind of an interesting thing because we both thought it was silly and would never work. And then we found out that it did work, so Phil set up an institutional review board at Capital, and we did an ongoing research project with it. When Capital ran out of funding and was going to go under, then Phil and I wanted to carry on our research, our education, our clinical instruction, and so we formed the American College of Integrative Medicine and Dentistry. In doing that, Phil was invited to go to South America, to Brazil, to lecture, and when he was in Brazil, he met Dr. Lamberto Ray, who is a pharmacologist, an MD pharmacologist, and he teaches at the University of Ancona Clinical Pharmacology and Toxicology in Ancona, Italy. You can't do ozone therapy anymore in Italy unless you take Dr. Ray's course. And so Dr. Ray came here to the U.S. in January 2007 to Phil's office, and we taught 2 courses in Phil's office that month, with Dr. Ray being the primary lecturer. And when he was there, he introduced us to this concept. We're enhancing your injection techniques using ozone in the skin area. And so the injection techniques he talked about were intradermal, subcutaneous, and intramuscular. And the reason that he was doing this was they did some research and to find out what were the different reactions they were getting with the ozone injections they were using. And so they looked at the reactions of ozone with cells and with body fluids, and know that ozone dissolves into the plasma and extracellular fluids immediately. And when you inject in the body tissue, whether you're injecting it and you get into a vessel or you get into subcutaneous tissue, the ozone reacts dramatically and immediately and starts breaking down into very beneficial products for the body. So why would anyone expect a physiologic response to ozone injections? Dr. Ray was asked that question by us, and he said, well, ozone injections are documented to produce these results. They give you localized oxygenation and analgesia at the point of injection and surrounding. It causes muscle relaxation. You get vasodilation, hence more blood flow because it releases nitric oxide locally. You return the muscles, which are full of lactic acid from anaerobic muscle function, you return them to aerobic function because you reverse the lactic acid formation by dumping in electrons and oxygen, and you get the biochemical response you want to have the muscles return to their normal aerobic muscle metabolism. And when they do that, you have an oxidation of the lactate that's formed by muscle contractions and the anaerobic muscle metabolism back to lactate, from lactate rather back to pyruvate. And it neutralizes tissue acidity and increases the synthesis of ATP. And it causes calcium reuptake and normalizes membrane function because it normalizes charge repulsion that occurs in the tissue. It reduces swelling in the tissue, and you release endorphins, which are the body's natural pain relievers. And it gives you a capsaicin-like reaction in that it alters the pain receptors locally in the area. So like when you rub that hot pepper cream on, and it gives you a little bit of a capsaicin-like reaction locally. So Dr. Ray, we looked at the normal skin structure, and we looked at what was going on there with the different layers, the epidermis and the dermis and the subcutaneous tissue. And we said, well, what is going on there? And he said, well, let's look at some normal skin here. And skin is composed of 2 primary layers, the epidermis, which is ectodermally derived, and the dermis, which is mesodermally derived. And what happens in this tissue is there's a certain cells in there that will react with the ozone, and we're going to have that in the next slide coming up. But the hypodermis is also referred to as a subcutaneous tissue, and it's loose connective tissue. There's a lot of fat in that tissue, and when you inject anything into that tissue, whether it's ozone or any medications, you get a kind of a delayed reaction to the medicine, in that it's like released over a 24-hour period. So you can get kind of a slow time-release reaction with your medications or your ozone when it's injected subcutaneously. And the skin functions as a barrier to physical, biological, and chemical agents and to radiation. Helps with thermoregulation, with perspiration, heat radiation, with blood circulation, and a minor function in most humans of, not giving you insulation, although some of us are better insulated than others. And so that would refer you to Phil, except he's lost 50 pounds. So, he's not as well insulated as we used to be. But it's also photochemical production of D3 as happens in the skin. This is what's interesting, in that it's cholesterol that produces the D3. And if you take a lot of Lipitors and statins and you shut off your production of cholesterol, guess what happens? Your D3 goes down. Now, there's all this controversy out here right now about, is D3 really good for you? How much and there's all this shifting thought of D3 right now. So you guys need to look at that, because that's a pretty important thing. And I think that you need to do the testing on your patient, which can be done very easily with a finger stick, and find out if there's any D3 problems, because that can be a big thing, because D3 helps you with your own natural immunity. And the skin serves as a sensory organ too. So we want to determine, by the research that they did, does the depth of the injection into the tissue produce any kind of a different physiological response. Specifically, if we inject into the dermis, into the hypodermis, or the subcutaneous tissue, or in the skeletal musculature. So, in order to get everything in on this session, I'll stop and take questions, but we really don't have time for that today. So I'm going through this kind of quickly, but we got a handout to give to you all, and plus you'll get the DVD of this. So we'll look at the specific responses now, and this is the handout that I gave you all. An intradermal injection produced an antioxidant response, and that's documented in peer-reviewed literature. So you get an antioxidant response then. And subcutaneous tissues produce a vascular response, or opening up of that vascular beds, improving circulation to the area. And the intramuscular injections produce an anti-inflammatory response. So has anybody here ever taken any courses from Dietrich Klinghardt? Okay, so we've got a couple guys that know Dietrich. Well, the Germans believe that you inject little mosquito bite-like areas over the organs or over areas of dysfunction. They call them quaddles. And they've been doing this for years with procaine, with no-sodes, with all these various and sundry homeopathics. And so they knew they got a response, but they really didn't know why it was responding that way. Well, now with the new literature review and the new ways that we have of documenting this, we found out how this stuff is working at that level, which was earlier when I said about, what the physiologic responses produced are. So with this, the subcutaneous injections, you'll see that a single subcutaneous injection of ozone prevents allodynia. Allodynia is pain that is not normally produced by stimulation. So it's it's a different kind of pain, and this is in the expression of pro-inflammatory caspases in the orbitofrontal cortex of neuropathic mice. So they did this research in Italy, and this is from 2008. So all this stuff is new and late-breaking information. So where's the science? And that's what, an IAOMT always asks, show me the science. So the science was there in that article, and then Bocci has 2 books, or Bocci, on ozone that's been printed with hundreds of references in these books. Ed Lynch in England produced this book, Ozone, the Revolution in Dentistry. Again, hundreds and hundreds of references in here to how ozone works on teeth and in root canals and periodontally. So besides medically, we have dental literature that shows that. And Catalytic antibodies and ozone are proposed to be part of the water oxidation pathway, a series of reactions unleashed by the immune system to kill bacteria. Now, we're not looking at Italy anymore, or England, or the Pacific Rim, or anywhere else for this research, because guess where that came from? Scripps, La Jolla, California. Okay? Now, there's nobody that can argue with Scripps. I mean, they do the best research anywhere. And this is from 2002. So we're almost 9 years out from this article. So what you need to know is the ozone is produced in your body, and it's produced to kill bacteria, virus, and fungus. This is a reaction that occurs when ozone's produced. But in order for it to work, you need IgG. So IgG catalyzes this reaction and produces hydrogen peroxide and ozone. So there's your natural killing occurs in the plasma cells and white blood cells in your body. So this is the natural way the body kills. And no one ever knew that ozone was produced in the body until Wentworth did this research. And this is in the journal Science. So this is, again, peer-reviewed. He's done a couple other articles since then. So here's some more information on where the science is. Ozone goes into plasma, and when it does, it breaks down in a fast-reacting substance that's called reactive oxygen species. And the target of reaction oxygen species are your red blood cells, and it improves oxygen delivery to the tissues, which we said earlier in that little list of things that ozone does. Works on the white blood cells and activates your immune system. In the platelets, it releases autocoids. Autocoids are like hormones that are produced in one part of the body that act in another part of the body. And they growth factors, like platelet-derived growth factor to increase healing. Then you have your endothelium that reacts in the slower. This is the time-release part of ozone, lipid oxidation products. It reacts on the endothelium, the lining of the blood vessels, and releases nitric oxide. There was something called endothelium-derived relaxation factor that until in the late 90s, no one really knew what it was. And then they did the research and found out it's actually nitric oxide that's being released in your body to dilate the blood vessels. And the bone marrow, you'll get new erythrocytes made by the bone marrow that are capable of carrying more oxygen. So they're super gifted erythrocytes. And even more importantly, it releases stem cells. So when you inject ozone like into a TM joint, like I'll do a lot, you'll get a lot of rebuilding that occurs in the TM joint because you get rebuilding of the cartilage and rebuilding of the bone. And Pam's shaking her head out there saying, yeah. So, because a lot of y'all have been using this and seeing the results that are happening with this. And then other organs, upregulation of oxidative stress proteins and antioxidant enzymes. And you need a small ozone dose or hydrogen peroxide for your body to actually make your own antioxidant enzymes. So intradermal physiology. So what goes on when you do an intradermal injection? Well, here's what happens. The fibroblasts are there to synthesize and degrade fibrous and non-fibrous connective tissue and matrix proteins. The macrophages, which are going to go through and clean everything up, they process and present antigens to immunocompetent lymphoid cells. So if you've got something that's infecting you and you inject ozone in there, it kills it. The white blood cells then can phagocytize it and eat it. When they do, they recognize that as an antigen. They run over to the major histocompatibility complex and say, look what we found. We need an antibody for this. And the immune system goes, yeah, you're right. Where'd you find that? Well, it was crawling around in the skin. And so you make an antibody for it, and they make the white blood cells and the plasma cells that then create ozone and hydrogen peroxide to kill all these things. So this is just upregulating your whole system and making you a lot healthier. And then mast cells are there, and you get the immunoglobulin E, and this is what is mediated in acute, subacute, and chronic inflammation. So you quench that inflammatory response with ozone. And the other functions of the fibroblasts, macrophages, and mast cells, generally, and I condensed all this down, coagulation. They help stop bleeding. Wound healing, they're going to speed your wound healing up. And tissue remodeling, they'll tend to make scar tissue less prominent when you're injured. Subcutaneous tissue physiology, composed primarily of adipose tissue, but we have nervous tissue in there also, and blood vessels, arteries, veins, lymphatics, hair follicles, sebaceous glands, and sweat glands. And so the subcutaneous, like I said, it gives you a kind of a delayed action there. So diagnosis and treatment. So how is it determined when a patient needs antioxidant therapy vascular enhancement therapy, or anti-inflammatory therapy. And would any of these treatments be harmful anyway if we did all three of them to the patient? Of course not. So when you look at the skin then, and we're going to look at our injection sites, we're going to say intradermal injections give you the antioxidant response right into here. And then subcutaneous injections give you the vascular response. And intramuscular injections give you an anti-inflammatory response. And this is real good for trigger point injections in any of your head and neck pain patients. Dramatic changes when you inject this. So these are your anatomical considerations. This is the second page of the handout that we gave you. And here's your intramuscular. You're going to go in 90 degrees down into the muscle layer. And subcutaneous angle at 45, and intradermal you angle at 10 to 15. Well, about 75 to 80% of the time, I do all three of them. I'll do I'm going to do a trigger point. I'll inject right into the intramuscular, and I'll leave about a half a cc of ozone there, half a milliliter. I'll pull out and angle off a little bit and leave some subdermally, about a half a cc in there, half a ml. Then I'll pull out and angulate, and I inject then until I see a bleb occur in the skin. And you'll see, because we got some slides that'll show that. And that's my intradermal injection. Now I've covered the waterfront on that patient. They've got everything: antioxidant response, a vascular response, and an anti-inflammatory response. So, you know, why, if you're going to have the needle in there, why don't you do all three of them? Yeah, bam. Yeah, I do it with one injection. I go in and as I come back out, I'm injecting, because I don't want to inject intradermally right when I first go in, because then that bleb gets in my way as far as going in the rest of the way. You'll see we got some slides coming up here. 1 inch, 30 gauge 1 inch. And you get somebody that's really a big guy or thick-skinned or a lot of weight on them, then I'll use 1 1/4 inch 27 gauge. Because once you get over an inch, the 30s are too whippy. They're too flexible. So I'll just go up to a 27 gauge 1 1/4 inch in a larger person. So, and this is what happened, and the oxygen ozone's getting into the tissue, and like I said earlier, it's going to act on the pyruvate, it's going to act on your mitochondria, and you're getting aerobic function, because you're negating the anaerobic response there of pyruvate, which breaks down to ethanol or lactate. So here's one way if you just want to do an intradermal injection. Say you've got a little problem in an area, say like a basal cell carcinoma, and you want to inject underneath it. Bend your needle that's a 1/2 inch needle. You bend it at about a 30-degree angle there, and the syringe is full of ozone, and you stick it in the skin. And by doing that with it angled like that, you can slide right in under the skin. And then you inject the gas in there. See the erythema starting right here? So this doesn't show up real well, but when you inject this, the skin starts lifting up here. So I keep injecting there. And now you can see this. Can you see the skin lifting up right here? See it blanching slightly there? So that's lifting this little bubble up that we're looking for in an intradermal injection. Now it's really lifting up. And that's about 1 ml injected there. And we're doing this for like people that have head and neck pain. So I do a lot of trigger points there. Now, this is the cocktail solution that Phil and I started using. Frank Schallenberger was real instrumental in getting us to use this type of injection here. And this is procaine and B12, methyl B12, and folic acid. And this, again, I'm doing a subdermal injection here. And you can see the skin tissue lifting up there. And then there's what you leave. That's that little mosquito bite thing. Now, why would we want to do that? Well, if I'm going to inject her TM joint with ozone, I do this first. Because now I've prepared the tissue with this oxygen-enhancing B vitamins. And procaine is the only anesthetic that's an ester. It's held together by an oxygen. So you have PABA, oxygen, DEAE. So when it breaks down, you leave 2 B vitamins and an oxygen. whereas lidocaine and the other ones are amide links, and they break down, they leave an NH3, which is positively charged, which increases the acidity of the tissue. So we use that, and then you can go in right in there and inject ozone into your temporomandibular joint to get it up and running again. So here's the 1-inch needle, and I'm inserting it, and then I inject on the way out, and that's what I leave on the way out. That's the last thing you see when you come out from the intramuscular, intradermal, or intramuscular subcutaneous, and that's the intradermal right there. So you can do it with a 1-inch needle also. So you just stop right when you feel your needle pulling out, and you inject. You can see some of the fluid is running back out because I'm really, really right there at the skin tissue level. And again, we look at that, and just to review that, you want to go in all the way to the depth of a 1-inch needle, and you're in the intramuscular tissue. And you pull out and leave some in the subcutaneous, pull out and leave some in the intradermal tissue. And this gives you a dramatic response in a lot of patients. They just get incredibly better with their head and neck pain. So this is part of everything that we do, which is foundational integrative dental medicine. We also have the patients on nutrition. We support them homeopathically and naturopathically with biological remedies. We want to get their pathogenic load reduction down, so we do other ozone therapies like injecting into the pterygoid plexus, and we do auto-regulation, auto-detox. These are remedies that we give the patient because we're big into the oral systemic connection. You just can't say the mouth is disconnected from the body anymore. We've got to look at the whole person.